gives us an indication that you're at risk for silent aspiration. It doesn't give us any insight into your risk of aspiration, right? We've got to assess swallowing physiology for that. If not coughing on oral trials is an indication that things are normal, that's exactly what someone with no airway sensitivity is going to look like. So I teach a course in critical appraisal of literature, and I'm always saying, if a study can't get a message across to you as a clinician, don't question your intelligence as a clinician. Question the purpose of a paper that is not easy to digest. And then as I'm reading this, I'm like, crap, that's me.
Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speechies, especially those working in home and community-based settings. My name's Chantal, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. We're joined today by Dr. Phoebe Macrae, who is an Associate Professor and Director of the Rose Centre for Stroke Recovery and Research at the University of Canterbury in Christchurch, New Zealand. Her research focuses on swallowing neurophysiology, dysphagia, and the role of sensation in upper aerodigestive function. She was recently awarded a prestigious Rutherford Discovery Fellowship for a 5-year research program titled Cross-Disciplinary Characterization of Upper Aerodigestive Function, which draws on collaborations with respiratory medicine, physiotherapy, otolaryngology, and engineering to explore the links between respiration, swallowing, and coughing. Dr. Macrae completed her PhD in dysphagia neurophysiology at the University of Canterbury under Professor Maggie Lee Huckabee, followed by a postdoctoral fellowship at Johns Hopkins University with Dr. Ianessa Humbert before returning to a faculty position at the University of Canterbury in 2014. So the article we're basing our discussion on today is called The Influence of Cough Reflex Testing on Patient Management. It was published in 2024 in the Journal of Speech, Language and Hearing Research, and it looked at how cough reflex testing results actually influence clinical decision-making. Using hypothetical patient cases, the researchers asked speech pathologists what they would recommend for diet and instrumental assessment across 3 scenarios. Patients who had a clinical swallow evaluation only, patients who had a clinical swallow evaluation with a pass result on cough reflex testing, and patients who had a clinical swallow evaluation with a fail result on cough reflex testing. Okay, so thank you so much, Phoebe, for agreeing to be on the podcast. Really excited to talk to you. First thing I want to ask you is, why did you decide to research this particular subject of cough reflex testing?
A lot of my research is in cough reflex testing. I do quite methodological, really minutiae detail stuff. And that obviously leads to a lot of conversations about cough testing, which I really enjoy because that brings me back up to a level of what's applicable. How do we make this clinically useful, and where's it going? So we've had lots of conversations within our lab group, so with my postgrad students and with clinicians, local and international, at different conferences and stuff, about how we use cough testing and what it offers us and what we can do with it. And I guess what we tended to see, or what we anecdotally were kind of noticing, is that like any tool that we get, we sometimes can over rely on it. If you think about cough testing, and my understanding of cough testing is, it's a screener, and it's a screener that gives us an indication of risk. It's not a confirmation, but it's also a screener for risk of silent aspiration, not aspiration, right? Mm-hmm. So, and we can get into that more, but using it to make firm decisions, based solely on its own information is something that I think is over relying on it for. Mm-hmm. But in the same way, it offers really good information that we should be factoring into our clinical decision making if we have it. And so we wanted to see how exactly it is being used, and is our clinicians who are using it, or are clinicians who are aware of it, finding it useful, or is it having any impact on their decisions for patients? And so there's quite a bit of research out there on cough reflex testing, but when you do this kind of assessment, when you do this kind of research in clinical settings, it's very hard to control. You're dealing with a whole bunch of different clinicians who have different clinical decision-making pathways and processes. And then you're dealing with all the different patients and the variability that they bring to that. So finding how the cough test itself influences things is actually really difficult, and you can't really tease it apart from all the other things that are in play there. So while there are definitely limitations of experimentally kind of inducing this type of research, it gives us a way to control some things, to say, okay, what specifically is cough reflex testing results adding to the clinical decision-making process, because we can control that. So that's kind of where this came from, is finding out a wee bit more about that.
The title of the article, the research, is called The Influence of Cough Reflex Testing on Patient Management. So can you talk us through or give a bit of an overview of what this particular study was looking at and how you went about it?
In reviewing the manuscript and reading it, and I'm like, gosh, it sounds just so straightforward, and how we came to it. This was so many conversations and so many hair pulling situations trying to work out how to essentially what we did is we formulated two hypothetical patient cases, and we differed them only really by their inherent risk of developing aspiration pneumonia. And we based that on Langmore's hallmark study looking at aspiration pneumonia risk factors. So we worded them quite differently, but essentially the blocks of those two patient cases were pretty much the same, apart from one had risk factors for developing aspiration pneumonia and the other one didn't. So we wanted to use two very similar patients who just had a different risk level and see how clinicians changed their clinical decision making relating to diet modification, relating to decisions on management according to their cough test result. Yeah, we developed these two cases, and it just got more and more complex. We had to peel it back, and it got more complex again. But essentially what we did was give minimal detail for a basic clinical swallowing evaluation, like a bedside evaluation, really basic information for each of them, because we didn't want a whole lot of overinterpretation of what was coming. We kind of just factored in the things that we think are really basic level stuff you need to be able to push forward with an assessment or know about a referral that you're getting. Then we invited clinicians on a survey, and we gave those clinical scenarios to clinicians without any cough testing information. We asked them to tell us what they would do for diet recommendations, so oral versus non-oral, whether it's modified or baseline diet, and also tell us what their management plan would be. So they used those same cases, and we said, right now we've added either a cough reflex test and they've passed that, or we've added a cough reflex test and they've failed that, and given them the same scenario. What's your decisions? What would you decide, and how would you push forward with this patient? So essentially each person rated 6 clinical scenarios. And if you can, it gets a bit complex, but if you can imagine, you've got these 2 patients with 3 scenarios each, right? So we've got 6 scenarios. No cough testing information, just a basic clinical swallowing eval, and cough test alongside the clinical eval when they've passed, and the cough test when they've failed. And then we looked at what their decisions were and how they related to the other conditions, to see the effects of the cough test result, but also the effects of the risk factors in terms of aspiration pneumonia development. Because if you think about it being a screening tool, and it gives you a bit of an indication of risk of silent aspiration, we should be integrating that information differently if somebody has other risk factors that makes them much more likely to develop aspiration pneumonia, right? Like versus someone who has no other risk factors and really they've just failed a cough reflex test. We're probably going to be less cautious about them than we are with someone who's. So you couldn't really assess the effects of cough testing without factoring in other risk factors as well. So that's what we did.
Yep. And so just remind me again, what was the difference between the 2 patient scenarios?
Yeah, so we worded them quite differently so that they looked like different patients, but the difference between them was there were 3 risk factors that Langmore's study had identified as being predictive of developing aspiration pneumonia. One was a history of smoking. The other was a complex medical history, so multiple diagnoses, and the other one was oral hygiene.
Yep.
So we didn't know how this would go, because all 3 of those, I mean, aside from oral hygiene, I guess, it's not something that in the wheelhouse of being an SLP, you kind of think, well, a complex medical history, I need to be more wary. I mean, we do those things, but actually having them at the forefront of your mind when you're focused on, swallowing physiology and aspiration, they are things that, because we know from that study that actually dysphagia and aspiration itself are less predictive of developing aspiration pneumonia than some of those more broad patient concepts. And so that's what we included in one of the patient cases and not the other, to make them higher risk.
Yep, makes sense. For people who don't understand what cough reflex testing is or how it's done, can you just give an overview of that?
Yeah, sure. There are lots of different protocols and lots of different methods that you might use, but the thing that ties them all together and the crux of a cough reflex test is that you want to nebulize some irritating stimuli. So we call it tussive stimuli, and that just means something that will make you cough. We use citric acid, other people use capsaicin or tartaric acid, but essentially you're nebulizing a tussive stimuli into the airway, so they inhale or inhale and exhale, and as it reaches the airways, if you are inhaling something that's quite high concentration and it's tussive, it should make you cough. If you've got intact airway sensation, you should respond with some kind of protective mechanism like a cough. And so if we're blasting your airways with 0.6 moles of citric acid, you should be coughing and your eyes should be watering. And if you sit there smiling and you're deeply inhaling and you're staring back at me like nothing's up, alarm bells are ringing that something's not right in your airway sensation to be detecting that noxious substance and doing something to protect your airway. And so essentially it's a screening for saying the airway looks to have sensation that's working, or it's intact, or it's completely dulled out. It's very hard to be quite precise when you're using clinical methods of cough testing. But if you don't cough to something major like that, then alarm bells are ringing. You'd probably want to take a more cautious approach. It gives us, what it does is, I think this is the point where, because it is quite a complex process, and if we're looking at it as if somebody doesn't cough, yes, we want to be very aware of what that means. It means that if they are getting something down into their airway, it's going below the vocal folds, they're at a higher chance of not responding to that. So we may be looking at a silent aspirator. Okay, so that when we're evaluating them clinically, they look totally normal. They look like they're managing things really well. And the other people that are most at risk, we know that your chance of developing an aspiration pneumonia is much higher if you silently aspirate versus overtly aspirate. Probably because of how you're managed and what that does for your airways. So it gives us an indication that you're at risk for silent aspiration. It doesn't give us any insight into your risk of aspiration, right? We've got to assess swallowing physiology for that. It really is specific to it gives us insight into the potential response should something go down the wrong way. And I think that's the distinction that we've had through multiple conversations with lots of people, is don't jump to the fact that they're aspirating.
Yeah.
It's an indication that there's a risk there, that we're missing information if we're assessing them at bedside and just judging on whether they're coughing or not. And it needs further investigation. Cough reflex testing is not swallowing physiology, it's airway protection in response to something noxious getting in the airway. So it's one piece of the puzzle.
And so what are the clinical indicators to use cough reflex testing? Is this something that we should be including as standard as part of all of our clinical swallow evals, or are there certain things that we would be looking out for that would tell us, okay, I want to do cough reflex testing now?
It's such a difficult, it's not a difficult question. It's an interesting question. I think we get asked that all the time, and what the benefit is and who we should be using it with. Some populations just don't have any more risk of blunting of your airway reflexes than your normal population, but some do. We in New Zealand, a large number of the hospitals here use it routinely, the protocol for stroke patients, to make sure that if sensation's been knocked out to the airway, we're not shoveling food and drink down there in the first couple of days and putting them at risk of an aspiration pneumonia because things have changed drastically. I think what I've always come down to with this conversation is that it's pretty easily implemented. It's a very cheap test, and it should never be viewed as it's not instrumental. It's not your answer to everything, but it gives another piece of the puzzle. And this study actually shows us that quite nicely. And we'll talk about that as we go through, but it gives us some indication that if we have the information about patient airway sensitivity, we are going to use that information, and we use it pretty well. It informs our clinical decision making. And so it's a pretty cheap test. And if it becomes routinely implemented, it offers us another piece of the puzzle, essentially, for helping our decision making. Yeah.
And so just to clarify, if we were to do a clinical swallow eval and someone had everything looked pretty normal, in regards to their swallow, do you think we still need to do cough reflex testing if everything seems okay and we're not actually concerned about aspiration?
Yeah, I guess what I would say to that is if everything seems normal, what your indicators of that are, right? So if not coughing on oral trials is an indication that things are normal, that's exactly what someone with no airway sensitivity is going to look like. They're going to smile at
Mm,
you if things are bucketing down the airway. I think you probably need indicators that there's something going on. Maybe a thorough cranial nerve exam, I think, is a must. I think you have
yep.
to have that, and you have to see. It gives you insights into these things that we can't see in the
Hmm.
pharynx or the posterior part of the oral cavity. Really difficult to see. If we use a really good cranial nerve exam, we might get an indication that actually if something's off there, we might be expecting something we can't see is also off. Volitional cough doesn't give us the same information. We get that question all the time. Volitional cough gives you an indication of how strong someone can formulate, subglottic pressure to generate a cough. It doesn't give you an indication of will they trigger that cough when something goes down the wrong way. We're looking at the sensory loop part of that whole response.
And how accessible is this outside of a hospital? So, for speechies who are working in outpatient clinics or seeing patients in the home, how feasible is it for them to be doing this test? And do you think there is a place for it outside of, an acute sort of setting?
Yeah, I do. And I think that's something I was going to touch on about this paper is actually we see that we use it when we've got it, but actually it's same here in New Zealand. I know that community settings and outpatient settings are less likely to run a cough test. It's more of an acute setting thing. It's not that I would say, well, we need to have it everywhere. We need to be able to assess the I guess it's being aware of, and when we discuss the finding, it's being aware of what our tendencies are when we don't have the information on someone's airway sensitivity so that we can then put measures in place to mitigate any risk that comes from those decisions. But also to answer that, yeah, it is really simple. We use it in a research lab, and you just have to team up with a pharmacist.
Now, let's talk about the study. So, tell me a bit more about what you found. What were the results?
Right. So, let me think. I've made some notes because it got quite complex there for a while. But essentially, if we break it down to a few different things, the analysis, if you read the study, it's like, okay, you could get a bit lost in there. And so
I
I'm
did a
always
few times. I had to read multiple times in the results section. Yeah.
Yeah, I teach a course in critical appraisal of literature, and I'm always saying, if a study can't get a message across to you as a clinician, don't question your intelligence as a clinician. Question the purpose of a paper that is not easy to digest. And then as I'm reading this, I'm like, crap, that's me. I reckon. But it's so hard to convey analysis in a way that needs to. But what I think is really important is that your results are clear, your discussion is clear, and you can
Yeah.
take on some points. So in terms of what we saw here, so if we've got these clinicians answering questions about this high risk patient and this low risk patient according to whether they've got cough reflex testing results at all, and then whether it's a pass or a fail. So what we saw is that when they're making decisions on oral intake, whether they would stick with the patient's baseline diet or modify the diet or put them nil by mouth, or whether they couldn't make a decision. If you have a cough reflex test fail result, clinicians are more likely to recommend a more restrictive diet than if you've passed the cough reflex test or if you haven't got any cough reflex test information at all. And they're also more likely to report being unable to make any decision about diet until they've got instrumental exam. So that all
Mm,
makes sense, right? That's really kind of logical problem solving, decision making stuff, which is nice because we
yeah.
don't often have a chance to go, are we doing this right? A patient with low risk factors for aspiration pneumonia, so the patient case that we didn't have, a history of smoking, poor oral hygiene, and complex medical history, was more likely to be recommended a less restrictive diet. So if you don't have
Hmm.
those risk factors, as SLPs, we are factoring that in and going, actually, we don't need to be as restrictive with this person. So that was, and they
Yep.
were really subtly provided. So it's quite nice to see that we are, in general,
Mm,
taking account of the big picture of the patients. Interestingly, though, across both of those, so when we look at when we don't provide any cough test information at all. So we're giving just the clinical swallowing eval.
Mhm.
Recommendations are very similar to what we recommend when a patient passes the cough test. What that's suggesting is that in the absence of information on airway sensitivity, we are either presuming that it's intact or we're not really
Mm.
factoring it in as part of our decision. I think that's what I was referring to before. So the two patient cases differed in their smoking history, medical history, and oral hygiene, as
Mhm.
Langmore study indicates. But their basic clinical swallowing evaluation included a reason for the patient's referral, their medical diagnosis, their current general medical status, and basic information relating to the patient's cognitive function, and a summary of the results of an oral motor examination that included assessment of voluntary cough. We didn't
Mhm.
give biological sex, gender, age of the patient because we didn't want it to influence how, if you were across different settings, that might influence what you're feeling like you could contribute to the case. So we just kind of
Mhm.
left it generic as to the points that we think are important for assessing the risk. And we also found with a failed cough test result, clinicians were more likely to report they wanted instrumental assessment, and this was
Mhm.
approximately half of the clinicians. So it's really good. But if you consider that silent aspiration risk has to be confirmed with instrumental, it's likely that a strict protocol like we've seen in other papers like the DISP protocol or Anna Miles' study and Sarah Perry's study shows that if you dictate what the pathway forward is for a fail result, we probably
Mhm.
need something like that to get closer
Mm.
to 100% of these at-risk patients being assessed via instrumental. But I mean, also we're we're looking at this through the lens of a hypothetical scenario used in a survey. It's not, the patients aren't in front of you, you're not dealing with real risk. Those things are definitely going to influence what we've seen here, but just in terms of some general things that we noted, more clinicians were unable to decide whether they would go oral feeding or non-oral feeding, or what they'd do with feeding in the case of a failed cough reflex test. So that
Mm.
supports what we've seen previously, where the riskier we perceive our decisions to be, the harder we find it to make that
Mhm.
decision.
Yeah.
And there's quite a bit of research on that. So as the as the chips get higher, we go, "Ooh, I don't feel like I'm equipped to do this without a lot more information." Overall, what I think the take home from this is, or the kind of the big point is that when we're given information about silent aspiration risk, we do incorporate this into our decision making, and we do that differentially for a pass and a fail. We're more cautious
Mhm.
in our management of someone demonstrating risk, which is great. The part that we need to think more about as clinicians is that we give less restrictive diet recommendations and we decrease our plans for instrumental assessments for people who pass, but also people that we have no information available for. So,
Mhm.
despite not knowing the risk of silent aspiration for those patients that we don't have information for, we treat them in the same way that we would someone who's passed. And I think that's just something we need to be cognizant of, because I think that's where we can pull in. So I think this is a point at which we can actually think about different locations, not just, across countries or across different hospitals, but actually whether across settings, so community settings where we don't often have access to that, what can we take from it? And that's what I was alluding to before. If we're aware that our likelihood is that we're going to assume they've got intact sensation, we're not going to refer for
Mm.
instrumental, we're going to be less restrictive in our diet recommendations. If we're aware of that tendency, then we can probably do something to mitigate that risk without needing to change a whole lot of what we do, other than just thinking a bit deeper. And, are we dealing with someone who's demonstrating other risk factors for aspiration pneumonia? And if so, maybe we want to be more cautious about the fact that we don't know about their silent aspiration risk.
How often do you find that someone fails cough reflex testing, but then will overtly respond to aspiration when you do an instrumental? Does that ever happen?
Yeah, it does. And I've seen
Okay.
it. There are quite a few studies looking at the study by Anna Miles looking at sensitivity and specificity of cough testing is a good one. That, if you're looking at how many times it picks up someone who's actually silently aspirating, we don't have perfect sensitivity or specificity. And if we did, it would be amazing. It would be
Mm-hmm.
really good, but we don't. And we don't actually in any of the assessments that we use. If you think about using video fluoro, you bank on the fact that that person is going to aspirate in that instance that you are testing and under the situation that you've created, which is clinical, right?
Mm-hmm.
Um, so it's not perfect. And so we have people who are silently aspirating who pass a cough test, and we have people who fail a
Mm.
cough test who are not silently aspirating.
Do you know the percentages in terms of the sensitivity and specificity of CRT?
Yes. So Anna Miles did that in a study in 2013. I'm just looking at it, and it's good to pull that up if you're interested in those because it ranges. They tested three different concentrations and they looked at
Mm.
comparing it to video fluoro response and also Phee's response. So they did both. So sensitivity ranges from across the different concentrations from about 60% to almost 80%. So at its best, you're still going to be missing about 20% of people who silently aspirate when
Mm.
that pass a cough test. And on the specificity side of things, so the scenario you posed where somebody fails a cough test but actually isn't silently aspirating ranges from about 40 to 85 roughly. So again, probably about 20% of people who we, even at its best, we're going to get wrong.
Yeah, I want to talk to you about this phenomenon that's been found in a small group of people. I think in a couple of studies now. I know the one by Miles. I have a feeling that Katrina Steele might have also done another study more recently with someone else, and found a similar result in that a minority of patients, I think it was around 25%, if memory serves me correctly, of those patients who overtly aspirated on thin, they actually go on to silently aspirate on thickened fluid. So my question is, what role can cough reflex testing play in this, and what result would we expect to see for that particular population? Are we more likely to expect that they would pass or fail the test?
That's a really good question. And I think that study gives us it's one of those studies it's like, God, that's really good to have, but oh my gosh, that makes me question everything I do.
Yes.
For me, what I see that finding is it's another reminder that we need to be cautious about throwing all our thinking into any result that we get in one thing, right? So if you're doing a bedside eval and you're giving them oral trials and they're smiling at you nicely, don't think they're not silently aspirating. But if you get someone coughing and then you give them thickened fluid and they stop coughing, I mean, my first thought would be, right, we've solved the aspiration issue. And I think it was something like 11 or 15% of people actually then turn into, they were coughing and now they're silently aspirating. We know that's even more risky for development of aspiration pneumonia. So we're giving them thickened fluids that are harder to clear. I think that person theoretically would look the same on a cough test before they didn't aspirate and then before they aspirated. So your cough test isn't probably going to give you any differential information there. They're going to look the same at one time point and then act very differently on two different textures. And that was something that is worth mentioning, that though bolus viscosity, volume, all of those things, the same with video fluoro, it's going to influence your response. It's going to influence your what happens. And so what are we testing with cough reflex testing? It's a very broad brush stroke at we've got a gross measure of airway sensitivity to get to the level of specificity of picking up differences between bolus textures. We're way off that. I don't know if that'll ever happen, but yeah, it's another reason to be cautious about how we proceed with people who aren't coughing.
Something else I want to ask you. So I've been looking at some studies that have reported on silent aspiration rates, and it seems to roughly always be around 50%, which sounds like a lot to me. So, 50% of people are aspirated doing so silently. Are you able to shed a bit of light on why that would be so high? Like, is it because they looked at people who were critically ill? Maybe it doesn't apply to the average Joe in the outpatient clinic or whatever. But yeah, I'm just interested in hearing your thoughts on this.
I love this kind of conversation, and these are the conversations I love when we do our dysphagia intensive and host clinicians, because when you read papers and you see that same kind of stat reported out, what I think is happening there, and some studies have shown in certain populations up to 50% of dysphagic patients can silently aspirate. I think what you're seeing there is the use of the same reference. It's a worst case scenario. And so when you write grant proposals or when you're writing an introduction to a manuscript and you want to say, this is really impactful, this is important, you're going to use your worst case scenario. I've also seen studies that document 3% of patients silently aspirate, right? So I think if we look at it across the different methods that people use, the different patient populations that people are using, what they're classifying or how they're categorizing silent aspiration, I think we probably need to look somewhere to the middle for a more representative account of what silent aspiration looks like. And it changes a lot from very acute to even 2 weeks later, right? Like we see quite a big drastic change in patients in that time. And so it depends where in the recovery process you're looking.
And if speechies don't have access to cough reflex testing, what is the next best thing in terms of identifying silent aspiration risk from a clinical exam?
Yeah, this is where I think we're really lacking. We have very few ways to indicate the sensory aspects of swallowing and airway response. We've got very little, right? You might look at sensory response, how they report taste, what they're reporting in terms of things they notice in their mouth or when they're swallowing, but that is so subjective. And so, we don't really have something else that tests that sensory component of cough and your response to airway invasion. Volitional cough, as I said before, gives you an indication of what they can produce if they are volitionally trying to move something, but it doesn't say that if something actually catches in the airway, they're going to do something about it. And I guess further to that too, we know that volitional cough is a lot stronger. I use that word lightly because what does stronger mean? But we get a lot more oomph in a volitional cough than we do in a cough that's response to something going in our airway, because you trigger it faster without inhaling, whereas when you're a volitionally cough, you take a huge breath in and then you're generating a whole heap of force. So what you're seeing with a volitional cough is not what's going to happen even if that person is triggering a cough when they aspirate.
So I've got some questions here from some people when I mentioned that I would be talking about cough reflex testing. So the first question about cough reflex testing, what is our scope with the results? How do we treat for poor cough reflex?
Yeah, great. In terms of, it should be a piece of the puzzle that informs our management plans and our decision making for our patients. If we know they don't have good airway sensitivity, we should be more cautious on how we are monitoring them and what we're recommending as the way forward until we really know what's happening in there with an instrumental.
And if people do want to get in contact with you, have any questions, how can they reach you? Are you on socials? Is it email? What do you prefer?
Email is good. I'm awful on socials and have deflected all of the recommendations to get my research around social media, but I'm on email, which you can, I don't know if you can link that to this, but always happy to take emails about cough stuff.
Amazing. Yep, I'll pop that in the show notes. Awesome. Phoebe, was there anything else that you wanted to mention that we didn't cover on cough reflex testing?
No, I think that's good. Yeah, just I never discourage the use of more information in our assessments, but I think we also just need to be really cautious on how we're interpreting that and still using it as an aspect of decision making that guides our thinking.
Great. Thanks, Phoebe.
Oh.
Thanks for tuning in to the Dysphagia Research Bites podcast. If you want more dysphagia education, then head over to Instagram at Dysphagia Community or www.dysphagiabites.com. Bye-bye. I stuffed up my chopsticks.
One thing that you